Noswaith dda, a chroeso I chi gyd. Well, good evening everybody and welcome to our digital showcase today. You're very welcome. As you can see, the event is being recorded and we'll send you the link following the event, which you're welcome to share. My name's Colin Rydym. I'm President and Vice Chancellor of Cardiff University and I'll be hosting for this evening. You're all very welcome, as I've said. You're here tonight as part of the Cardiff community, comprising alumni, graduates who finished their studies at Cardiff, and also friends who are supporting the learning and research at the university. We're here tonight then to discover more about Cardiff's work in terms of our public engagement into cancer screening. And I'm delighted to be able to introduce two colleagues who are experts in this area and working actively in it. That's Professor Kate Brain and Dr Harriet Quinn-Scoggins from the Division of Population Medicine. And they're here tonight to discuss how the global pandemic and the national and local lockdowns that we're all so familiar with now, and the strain on the NHS, which has arisen from the COVID crisis, how's that all changed the way the public are making decisions to seek diagnoses, and what needs to be done to change public awareness into the future. And I think this is an area that all of us will have some experience of, whether it relates directly to cancer or not. And of course, almost all of us will be familiar with the issues around cancer through our family and friends or personally. Professor Kate Brain is Professor of Health Psychology and Personal Chair in the School of Medicine. Kate's research focuses on behavioural aspects of cancer control, in particular, understanding why it is that the public might wait before going to see their GP when presenting with symptoms, and why people don't take up cancer screening when offered the opportunity to do so. Her interests and ambitions with a focus on high-risk groups are to reduce socio-economic inequalities in cancer outcomes. Dr Harriet Quinn-Scoggins is a research associate. Harriet's a medical anthropologist with a particular interest in how we change the behaviour of groups of people, specifically those at higher risk of developing cancer. So the questions she asks are how, when can interventions make the difference between people seeking help, acting on symptoms, and accessing cancer screenings. So just a quick word on logistics before we get going. We'll have, first of all, the talks from Kate and Harriet, and Kate will hand over to Harriet once she's done her part. We do have 45 minutes till 6 p.m, so we'll be keeping to that time because I know everybody has organised or has events later on in their day. There will be time for questions and answers, so if you do have any questions, please put them into the Q&A box on your screen. It will be either on the bottom or the top, depending on your device. And we'll get through as many questions as we can in the time. So that's enough from me. I'd like to start now by welcoming Kate and asking her to give us her talk.
Well, thank you so much, Chancellor, for that kind introduction. And I'm delighted to be presenting to Cardiff alumni tonight because I'm also Cardiff alumni. So I did my undergraduate degree in psychology and then my PhD in psychology. And I'm hugely grateful actually to the university for supporting me over all of these many decades actually. I'm also thrilled to be co-presenting with my colleague, Dr Harriet Quinn-Scoggins. Harriet also graduated from her PhD in medicine in 2019 in Cardiff, and then she came to work with us in the Division of Population Medicine as a research associate. Harriet was also awarded a place on the Cardiff University Future Leaders in Cancer Research, the Flickr programme, and she graduated from that last year. So I'm going to start by introducing some of the background to our research on public awareness of cancer. And then I'm going to hand over to Harriet, who's going to present to you some of the findings of our COVID cancer attitudes and behaviour study. If I can have the next slide, please. So let's talk about the big C and why public awareness of cancer is important. So 1 in 2 people in the UK will be diagnosed with cancer during their lifetime. Almost half of cancers are diagnosed, unfortunately, at a later stage, although survival rates are improving due to improvements in early diagnosis and better treatments. So in general, detecting cancer earlier means that treatment can start earlier and have a better chance of success. But of course, that partly depends on people coming forward to their GP soon enough for cancer to be diagnosed early. However, early signs and symptoms can be quite difficult to recognise and act on quickly, and that can be one of the reasons why people may take longer to be diagnosed. So our behavioural research programme really aims to understand the complex reasons why people might not seek help or take longer to seek help. And then we use that evidence to develop and test interventions that are designed to support earlier help seeking. If I can have the next slide, please. So these are some news headlines from an international study that we carried out about 10 years ago now, where we were looking at differences between high-income countries in cancer survival rates. And the key headline finding at the time was that people in the UK were more likely than people in other countries to say that worry about wasting the doctor's time and being too embarrassed would stop them from going to the GP with a possible cancer symptom. And that was described in the media headlines at the time as the British stiff upper lip, and that's how it's been known since then. Now, we also found in this set of studies that people were good at spotting red flag symptoms, so things like an unusual lump or unexplained bleeding, but not so good at recognising and acting on symptoms such as a persistent cough or unexplained weight loss or breathlessness. And our research suggests that that's partly because these kinds of non-specific or vague symptoms can be more easily dismissed, or they can be put down to things like ageing or smoking habit perhaps, or minor illnesses and other pre-existing health conditions. So it's quite a complex picture, and this is why certain symptoms can be quite hard for people to spot. If I can have the next slide, please. Thank you. So very briefly, I wanted to include some quotes from a study that was carried out by another of our early career researchers, Dr Grace McCutcheon, who works in our team, because they really bring to life, I think, some of the barriers to early help seeking. And she carried out interviews with people living in some of the most deprived areas of Wales. The study was funded by Tenebus Cancer Care, who we worked closely with over a number of years. And you can see from some of these quotes that participants described fear of cancer treatment. So somebody said, a lot of people would rather die than go through the treatment. So treatment is perceived as being a horrendous experience. They also described fear of being diagnosed, and some participants automatically associated a diagnosis of cancer with death. And it's quite stark. So one of the participants said, phone the funeral director, I've got cancer. So this pattern of fatalistic beliefs about cancer we think it might partly reflect what people are seeing, what they're exposed to in their social networks. So if you're seeing people in your social circle or your local community who've been diagnosed later and then perhaps had poorer treatment outcomes, that might then create a sort of vicious circle of thinking, well, if you're going to get cancer, you'll get it and there's nothing that can be done about it. If I can have the next slide, please. So some of these findings, particularly the stiff upper lip findings that I described, were used to develop public awareness campaigns that you can see here. You might be quite familiar with these. These are the national Be Clear on Cancer media campaigns that have been run over a number of years by Cancer Research UK. So they've used things like posters and TV adverts. You might have seen things on the backs of buses to really try and deliver positive cancer messages on a whole population scale. And so we've got evidence, some of the research that we've conducted, for example, with the Welsh lung cancer awareness campaign, we can see that these campaigns have been effective in terms of increasing public awareness and encouraging earlier help seeking, and also improving cancer outcomes through earlier stage diagnosis, for example, with lung cancer. So we think that, we can see that important gains have really been made over the past decade in public awareness and earlier symptomatic diagnosis, which is good news. If I can have the next slide, please. So I'm sure you'll all be extremely familiar and probably quite sick of this message, the UK government message to stay home, protect the NHS and save lives. And of course, that was quite rightly intended to control the spread of coronavirus infection, but also potentially sent a strong signal to the public that cancer and other serious conditions could wait. The pandemic has really presented huge challenges for cancer services across the whole pathway, with the concern being that the gains that have been made in early diagnosis potentially being undone by COVID. And we certainly saw a big drop in GP referrals for cancer in April last year, and also the screening programmes were paused. So our concern really, based on what we knew from our previous research, was that the pandemic might have inadvertently, shifted public attitudes towards cancer and help seeking, with people not coming forward to their GP, partly because of not fear of infection, fear of coronavirus and catching COVID in healthcare settings, but also this sense of not wanting to bother the GP or to place extra strain on services that are already stretched. So an important part of the pandemic response is about understanding population behaviour during the pandemic so that we can then use that evidence to inform strategies for recovery. Next slide, please. So in May last year, we won funding from UK Research and Innovation to carry out this population study of cancer attitudes and behaviour, and that was part of their rapid response funding stream. So this is a population study of adults aged 18 plus to assess the impact of COVID. And really the overall aim of this study is to generate rapid evidence, and we can use that to inform public health interventions to encourage timely symptom presentation, to encourage engagement with screening and prevention in the wake of the pandemic. So I'm going to hand over to Harriet, who's going to talk you through some of the findings of the CABS study.
Next slide, please. So first and foremost, I'd just like to say thank you, Kate and Bo, for those very kind introductions. So the CABS study, we carried out the first population survey in August and September last year. Participants were recruited 3 ways: through Cancer Research UK's online panel provider called Dynata, through Healthwise Wales, which is a national register of research-ready participants, and through targeted social media recruitment using sites such as Facebook and Twitter. On the right-hand side of the screen, you can see an example of one of the targeted social media posts we used. Over 7,500 adults took part in the survey, which was more than double our recruitment target in just under 6 weeks, which was really amazing. We were actually quite shocked. Just under half the sample was over the age of 55 and female, and a majority of the participants were from a white ethnic background, and over a third had a university level qualification or higher. We also conducted telephone interviews with a subset of 30 participants to gain a better in-depth understanding of the influences on their attitudes and behaviours towards help seeking at the time. Next slide, please. Thank you. So before I start with the results, as Kate mentioned earlier, there are 2 main routes to early diagnosis. So people presenting to the GP with symptoms, or through people attending their cancer screening appointment to look for early signs when people don't have any symptoms yet. During the study, we collected data on people's attitudes towards both of these. However, most people with cancer, actually over 85% of cases, are diagnosed with through the first pathway, so through presenting symptomatically to their GP. So that's going to be the focus of our talk today, that data. So in the survey, we asked participants whether they had experienced any of the 15 potential cancer symptoms on the left-hand side of the graph over the last 6 months, so from March to August 2020, which covered the first lockdown and wave of coronavirus in the UK. On the graph, in the blue lines, are what we call non-specific symptoms, such as tiredness all the time. The red lines are red flag symptoms, such as unexplained lumps or swelling. And the green lines are lung-specific symptoms, such as shortness of breath and a persistent cough. Overall, 40% of participants had experienced at least one potential cancer symptom over the last 6 months. Symptom prevalence ranged from 1.5% of people having experienced coughing up blood to 21.3% reporting tiredness all the time. Breaking this down further, almost 1/3 had experienced at least one non-specific symptom, almost 1/5 reported experiencing at least one red flag symptom, and almost 1/5 reported experiencing at least one symptom possibly indicative of lung cancer. Next slide, please. Thank you. So thinking now about symptom presentation, that means, did the participants seek help once they had noticed a symptom they were worried about? We asked participants whether they had contacted the GP over the past 6 months and how long it took them. This graph shows the proportion of people who reported presenting to their GP per symptom they experienced. Again, all 15 potential cancer symptoms are listed on the left, with the people who did not contact the GP shown in light blue, people who did contact the GP in pink, and those who preferred not to say in dark blue. Results show that 45% of people did not contact their GP at all for any symptom experienced over the 6-month period. This included red flag symptoms such as coughing up blood at just over 30%, an unexplained lump or swelling at just over 40%, or a change in the appearance of a mole at nearly 60%. Almost half of those who reported non-specific symptoms, including a persistent change in bowel habits and a persistent change in bladder habits, had not sought help from their GP, whilst a higher proportion of nearly 65% reported being tired all the time and had not sought help. Around half of those experiencing lung-specific symptoms, such as a persistent cough and shortness of breath, had not sought help. Next slide, please. We also asked people to select from a list of barriers those that had put them off or discouraged them from seeking help from a healthcare professional during the first wave. You can see in the pink box at the top were the 5 barriers that were most commonly attributed, which was 1, worry about wasting the healthcare professional's time, 2, worry about putting extra strain on the NHS, 3, not wanting to be seen as someone who makes a fuss, 4, difficulty in getting an appointment with a particular healthcare professional, and 5, worry about catching coronavirus. Interestingly though, we found that remote consultations were not a barrier for most people. Next slide, please. So moving on to the interview findings, as mentioned earlier, we conducted 30 interviews with participants who had completed the survey. Just over half the interviewees were male, most lived in Wales, were from a white ethnic background and received a higher education qualification or degree. Again, the average age of interviews was over 55 years. So I'll cover some of the themes we identified in the interview data now. So in terms of symptom experiences, many interviewees reported noticing a change to their health during the lockdown, but they commonly put this down to changes in existing health conditions or possible side effects of medication. Participants described this as leading to a delay in their help seeking or not help seeking at all to avoid bothering the doctor when they assumed that they already knew the cause. Even where participants reported red flag symptoms, there was discussion of delaying due to concerns about the NHS being overstretched during the pandemic. Some participants conveyed the sentiment that the least they could do was help. The least they could do to help was to stay away from the NHS, which is a really strong message, we think. Next slide, please. Thank you. Participants also described a fear of help seeking frequently in the interviews. So fear of attending secondary care, so that's attending hospitals, was particularly acute, with some participants reporting being too scared to attend hospitals for appointments or procedures, even though they knew that this was not the best decision for their health. Participants described scaremongering media reports of hospitals being overrun with coronavirus cases and stories of those entering hospital healthy, leaving with the infection. However, most of those who did attend face-to-face in primary and or secondary care described feeling safe and secured when doing so. So this really surprised them, considering what they had seen or heard in the media. Because of this, several participants felt that they had been manipulated by the media into feeling scared and avoiding healthcare, which then had consequences for their health. Next slide, please. Thank you. So overall, when participants had contacted their GP, they were pleased though with the quality of care they received and the use of remote and/or virtual procedures, including new online and telephone triage systems. The use of telephone consultations was praised by most participants who had received them, with many reporting that with the new systems, it was easier and faster to get a GP appointment than before. Next slide, please. Thank you. So the key findings from our Wave 1 survey and interviews were that nearly half of the people with possible cancer symptoms in the first wave of the pandemic did not contact their GP, even for red flag symptoms that require urgent medical attention. Interview findings suggested that participants had put their health concerns on hold to protect the NHS and themselves and others from infection and to avoid burdening the NHS mainly. This suggests that the UK government message to stay at home, protect the NHS and save lives, which was intended to control the spread of coronavirus, also sent a strong signal that we were worried about to the public that cancer and other serious conditions could wait. The main barriers, as mentioned, were worry about wasting healthcare resources and burdening the NHS. There was also high levels of fear of catching COVID in hospitals, which could in part be due to media reporting at the time. Overall, this seems to reflect a possible shift in public attitudes towards seeking help for signs and symptoms of cancer, which may have contributed to the reduced number of GP referrals seen in primary care. However, there is a silver lining. The interview data did suggest that when participants had attended healthcare settings, they reported positive experiences and were supportive of keeping remote consultations as an option alongside face-to-face consultations in the future. I'll pass back to Kate now to finish the presentation.
Well, thank you for that, Harriet. So I'm just going to grab a couple of minutes, if I may, just to describe how, sorry, could I move on to the next slide, please? Just to describe how the study findings have been used so far and the impact that we're already seeing from the results. So the findings that Harriet presented were published in a press release and a policy briefing report at the end of February just gone. And in that we called for evidence-based and coordinated cancer awareness campaigns, really to reassure the public that NHS services are open safely and to encourage people to contact their GP promptly for any unusual or persistent symptoms. And we were delighted, there was huge media coverage at the time in the national and the international press. And we also, there was an interview by a social media influencer, Deborah James, who you can see here. She broadcasts the podcast You, Me and the Big C, if anybody's heard that. And she actually presented the findings on a live interview on Sky News. So we were really, really delighted with that coverage. Next slide, please. So then we shared the reports with lots of, well, over 40 stakeholder organisations, including the NHS, various charities and government bodies. And the study was referred to in the First Minister of Wales Question Times in relation to strategies for managing the backlog of cancer diagnosis and treatment. So we're delighted again that the key messages have already been embedded in various public awareness campaigns. So for example, on the top left, you can see the Get Check campaign, which Cancer Research Wales are currently running. And there are further campaigns that are being planned by Cancer Research UK. So we're doing what we set out to do, which is to feed those results into public health initiatives. Next slide, please. So in terms of next steps, we've collected a 6-month wave of follow-up data, which we're going to be rapidly analysing soon. And that will tell us whether things have changed and what has shifted in terms of public attitudes in later stages of the pandemic. We're also, again, planning rapid impact. So we're going to be turning out further policy reports and press releases related to the other areas of the study that we're collecting data on. And then we're also thinking about planning future research. So we're already thinking about testing various strategies for reaching different populations to increase equitable participation, and also working with partner organisations in lower middle income countries to help them, hopefully help them develop their population awareness strategies. So there's a lot going on. And then if I can go to my last slide, please. So I just want to, well, I couldn't finish without thanking all of the various people involved in the CAB study. You know, it is a fantastic example of team science. Lots of researchers involved across the university and also other universities working in collaboration, and you know, just really wouldn't be possible without any one of those people. So I just want to take the opportunity to thank them and to thank you all for listening.
Well, thank you both so much for that. That's really fascinating set of findings and an extremely important area of research. And it's great to see that it's already having an effect on public health initiatives, which is really good. So it's time for the Q&A session now. If you haven't asked a question, please feel free to do so using the Q&A box. We do have some pre-submitted questions to come to, but actually I noticed that one of the ones that has come in already on the Q&A actually matches up quite well with one of the submitted ones. So this is about what the research may have found for people from a BAME background and whether they have a positive experience of remote consulting, and also people with lower education levels or income. And I know that your research is looking very much at underrepresented groups. So could you perhaps come to that and what approaches you might be using to engage people?
Yes, so thank you for those questions. They're really, really important questions because we know that there are inequalities in cancer outcomes that are linked to ethnic minority populations and people from deprived backgrounds who may be less likely to engage in screening or to visit the GP if they do have symptoms. So the mass media campaigns that I talked a little bit about earlier on, there's evidence that they may not reach diverse population groups. So we've been doing a lot of work over the last few years working with, I mentioned 10 of Us Cancer Care, to develop more targeted, more intensive behaviour change interventions, working with local communities to understand their priorities really. So we've developed an intervention called the Abacus Health Check, which we recently trialled in a study that's funded by Yorkshire Cancer Research. I always have to acknowledge the funder when I mention these things, obviously. And so that was about trained peer supporters going out into local communities and delivering positive behaviour change messages on a one-to-one basis. So it was a really intensive piece of work. But the trial suggested that the intervention was really good at reaching people living in deprived areas, and was also effective in terms of increasing cancer awareness. So we're really, really pleased with the results of those studies. Now for this study, because of the way we've analysed the data so far, we haven't been able to drill down into sort of that level of population differences, just for technical reasons relating to the way that we've analysed the data relating to symptom experience, but we're planning lots of further interrogations of the data that may reveal those sorts of differences. So I hope that answers those two questions.
Great, thanks very much. Another one that's been pre-submitted, is there anything that comes out of your research that will help us support patients who perhaps were invited for screening, but for whatever reason didn't attend and then subsequently were diagnosed and realised that perhaps that could have been caught earlier, which must be quite devastating to learn that?
Yeah, it's a complex question. I think there's a few different things in there that I'll try and address. Yeah, absolutely. Receiving a cancer diagnosis can be devastating. There is a lot of research out there that looks to develop supportive interventions to help people cope along the cancer pathway, whether it's waiting for a diagnostic or screening test result, or coping with a cancer diagnosis, or living with and beyond cancer. But our research is really at the beginning of the cancer pathway, I suppose, and it's about trying to enable people to seek help and encourage earlier diagnosis when we know that treatment has a better chance of success. And I think Harriet mentioned in her talk that there are really two main routes to diagnosis. So one is, which we talked about tonight, which is about presenting to the GP with symptoms, and the other route is, of course, screening that can detect cancer at a stage before symptoms develop. And of course, there are lots of reasons, complex reasons why people might not attend their screening. It might be because they're fearful of what might be found, they might be embarrassed, there might be practical barriers, or they may feel that they don't have symptoms. So, taking part in screening is very much a personal choice. But as I said, our research is very much at the start of the pathway, with hopefully supporting earlier diagnosis.
Okay, thanks. We've got a follow-up question, actually. So, just to how we get to hear about progress with the research in the coming months, especially about reaching underrepresented groups and what works. So, how do you get the word out that people can follow what you're doing?
Well, I'll take that question, if that's okay, Harriet. So I think the main, the route that we found most effective is press releases, actually, which are linked to so we're planning policy reports at each stage as we sort of analyse data around screening, and then we analyse data around different aspects of the results that are coming out with the second wave of follow-up data. And I think probably the best press release, and then hopefully the associated publicity that comes with that, is the most efficient way of reaching a lot of people. We do also have, if people want to follow us on Twitter, that's another way that people can find out what's happening. And we also have a study website. So, happy to share more details if people are interested.
I'm sure we can do that. I think the Twitter and the website sound like good ways of keeping up with things. So another follow-up question, really, what would be the key change, the single thing we could change to help with the promotion and take-up of screening? It might be interesting to say how decisions on screening are arrived at. If you get an invitation to be screened, where's that come from? And how could we improve the promotion and take-up of it?
Again, I'll take that, Harriet, unless you really want to. Again, it's quite a complex question.
No, that's fine with me.
Okay. Yeah, so I think that, as I mentioned, screening it's all around informed choice. It's about encouraging people to consider the pros and cons of screening, because there's no such thing as a perfect screening test. Any screening comes with a certain amount. There are benefits clearly in terms of early diagnosis and detection, but there's potential for overdiagnosis. There may be a chance of having a false positive result where you get what seems to be an abnormal result, but then actually everything turns out to be okay. And that can cause a certain amount of, psychological of distress and anxiety. So there are things to be weighed up. But of course, it is about trying to reach different populations and to understand what the barriers are in different populations. And that's a huge area of research. I don't think there's a one size fits all. If there was, we'd be there. There's no sort of magic bullet, unfortunately, but I think it is about understanding what the barriers are for different populations, and then trying to develop, information resources and materials that can help to overcome some of those barriers.
It's interesting, isn't it? We've seen some of this with vaccine hesitancy, haven't we? People trying to reach various demographics and populations. And I guess the pandemic has really been clearly, from your work, a major factor in affecting all of this. And how do your findings compare to pre-pandemic times? Were people more likely to go to the GP with symptoms before the pandemic? In other words, has this made it worse, another knock-on effect?
Can I give Harriet a go on that one? Thanks,
yeah,
Harriet.
I'm happy to take that one on. Again, it's not an easy answer. So the data does suggest that, our results are lower than before pre-pandemic. Pre-COVID data from the Useful study, which is another study similar in methodology to ours, reported that just over 40% of participants didn't contact their GP on noticing a potential cancer symptom. But it's very difficult to compare exact figures due to methodological differences. So as much as the studies were similar, the differences are still there. So that study reported over 12 months, whereas we looked over 6 months. So the time differences need to be taken into context when thinking about interpreting those results. Our qualitative findings did suggest that people were putting their health concerns on hold, though, especially during the early months of the pandemic, when the fear, especially around attending healthcare practice was really very high, especially hospitals. You know, the acute fear really around hospital presentation. We're currently analysing, as Kate said, the second wave of data. So we're going to look at whether there's any differences now, obviously, as things are a slightly different landscape now as they were then. So I think that will be really interesting. Our results also mirror the data from NHS England, which suggested that people were not coming forward with potential cancer symptoms early on in the pandemic as well. They saw about a reduction in about 60% in urgent GP referrals for suspected cancer in England and Wales in April 2020, so that's a significant amount. And there's also more recent data suggesting that early cancer diagnoses in England have reduced as well, suggesting a shift towards later diagnosis with fewer people going to the GP with symptoms. There's also, you know, we need to consider things like delayed testing and longer waiting times too, due to the pandemic. That can also make a difference to delayed diagnoses. But the good news is that GP referrals did increase to around pre-COVID levels by the end of 2020, suggesting that cancer services are catching up. So there are definitely positives. I don't want, you know, it to just sound very negative. There are definitely positives.
It's interesting the way that some campaigns, which are absolutely, you know, sensible, like protect the NHS, might put people off because they think they're wasting time. And now we're seeing reports about, you just mentioned that, longer waiting times. Is that likely to put people off if they read in the media there's a long waiting time to get an appointment? Or?
In all honesty, I don't know. That's the honest truth. I think it is likely to have an effect. It's something, the waiting times is something that we explored more in wave 2, whether people are aware of, you know, the pauses in screening, the waiting times that are now there in the NHS. And the way that the current data is looking is that people are less concerned about delayed waiting times for themselves and more concerned about the health of others. So whether waiting times will affect their family or friends, or anyone in their close-knit relations. So what we often find in cancer research when we explore these types of issues, similar with the study that Kate discussed earlier in the presentation from Tenevis, was that actually people deprioritize themselves and put priority on others for their care. So it's really the concerns around delays at the moment are for those delays affecting others rather than themselves.
And does it depend on what type of cancer people think or fear they may have? Does that affect things?
Do you mean for worrying about the waiting times or about seeking medical help?
Consulting your GP. So, you know, if it's a particular type, are there particular types of cancer that people are just more reluctant to consult their GP about?
Yeah, so I think when it comes down to reluctancy about consulting the GP, I think it's really about the different symptoms and also things around stigma and health choices such as smoking. But when we think about the different symptoms that people have, the non-specific or vague symptoms are harder to recognise and act on quickly. You know, symptoms such as persistent fatigue or unexplained weight loss can be associated with such a large range of different cancer types and not, you know, just cancer, several other diseases. And obviously, you know, fatigue from lifestyle choices and everyday life, especially during the pandemic when, you know, we recognise that it was very high level stress and very new and different circumstances for lots of people. We are working with Cancer Research Wales at the moment to evaluate a targeted symptom awareness campaign designed to support the Rapid Diagnostic Centre in Cwmtaf, which is a one-stop diagnostic centre where GPs can refer patients with vague suspected cancer symptoms for diagnostic tests all in one place to try and remove some of those barriers for people and also make it easier for GPs. This includes a range of supportive interventions that are currently running in the community to increase public awareness, including community champions, who are trained lay advisors to encourage people and raise awareness to recognise and act on those less well-known symptoms such as fatigue and weight loss. But again, as mentioned previously, there is also quite a lot of stigma attached to some symptoms and some certain types of cancer, especially if you want to take into consideration lung cancer and smoking, because there is the stigma attached is often around blame, so almost as if the lung cancer is self-inflicted disease. So there are several studies going on across the UK at the moment, which colleagues and I are involved in, looking at lung health checks. So they're mainly community-based lung screening tests, including a CT scan of the chest of the patient. And so the reason they're being trialled in the community is to try and make them more accessible to the populations at the highest risk, and reduce some of the stigma attached. So it's really important that alongside the lung health checks, smoking cessation, which is the part of it that's often associated with the stigma and blame, services are there. So smoking cessation services to help people stop smoking are available, and combining the two can make it the most efficient and also the most cost effective. But it's really important that everything is delivered, as you can imagine, with, in a non-judgmental supportive style, to again reduce stigma and help people come forward and try and reduce that fatalism circle that Kate was talking about. If other people come forward, they have positive lung health check experiences, they learn about their health, they receive smoking cessation support, others in their community will view that as well, and then hopefully you can have kind of a social diffusion through that as well.
That's really interesting. We've only got a couple of minutes now, so I'm just wondering whether it would be good to round this off with a question about what we can do. I mean, that sounds like a really good initiative to bring everything in one place and take away stigma, and you can see how that's really going to help. But what if somebody watching recognises some of the symptoms we've been talking about here, either in themselves or perhaps in friends and relatives? I mean, what can one actually do as an individual in this sort of situation?
I'll take that question if that's okay, Harriet. Yeah, so I think it's the same message as we've been sort of feeding into things like the Get Checked campaign. So, if anybody, any one of us, anyone we know is experiencing an unusual or persistent symptom, then it's important that they contact their GP at the earliest opportunity, and also to be reassured that NHS services are open safely. Most of the time, in most cases, it won't be cancer, and people can be reassured. But if it is, then finding cancer earlier is what gives the best chance of a successful treatment. So, I think it's really important that we talk about, I talked about the big C at the beginning, it's important that we talk about cancer, and it's an important message to spread among our families, our friends, and also our local communities. So I would urge anybody who, themselves or someone they know has something that just doesn't feel quite right, then, contact your GP.
We've come a long way, haven't we, in terms of stigma around cancer, but it is still there. And, all of us have a role in being open and destigmatizing. So, well, I think we are pretty well out of time today. That went by very quickly. It was fascinating. So massive thank you to Kate and Harriet for your time and your expertise, and for some great presentations there. And a big thank you to our audience. I hope you enjoyed it and learned from it. If we didn't manage to get through all the questions, we will follow up with you directly. And we are very proud of the work we do here at Cardiff, the research that our fantastic academics do. And if you would like to support us or find out more information, there'll be a link in the comments. Just finally then, for me, we've got a programme of events coming up. The next one is understanding and supporting the developmental needs of children who need it most. And that's on Wednesday, the 9th of June at 5:15 again. And that will be staff from Cardiff's Neurodevelopmental Assessment Unit who will talk about addressing the needs of children who have various emotional, cognitive and behavioural problems. So you'll get an email about that in the next few days with a copy of the recording and links to register for that and other events. So that's it for tonight. Thank you all very much again. I hope we'll be welcoming you back to another event very soon. And goodbye, diolch yn fawr a hwyl fawr.